Tonight's topic is superbugs. You may have heard about these bugs. And tonight you're going to hear some new ideas about causes and cures of these bugs. I'd like to start with a quote from Oliver Wendell Holmes. "Every now and then a man's mind is stretched by a new idea, and it never shrinks back to its former dimensions." You're definitely going to hear some new ideas this evening. Our first speaker will be Dr. David Spock. He's a professor in internal medicine and infectious diseases here at the University of Washington. He received his medical degree from Duke, and he did his internship and residency here at the UW. Dr. Spock has numerous publications in very high-impact journals, including the New England Journal of Medicine and JAMA. He has also received multiple teaching awards, and we've listed just a few here for you. The first is from the Department of Internal Medicine for the high quality of teaching he provides to our residents and interns. The second is an award that he receives for the amazing lectures he gives in continuing medical education. These are often taken by practicing clinicians in the community. The third award is from this group called MedCon, and this is basically for the quality of consultations he provides to physicians throughout the entire Pacific Northwest. We often get calls from Alaska and elsewhere. And I think that you will agree at the end of his presentation that he's well deserving of these awards. So I'll turn it over to David.
Joanne, thank you very much. It's a pleasure to be here tonight. Let me start off by just asking a question. How many people in this room have ever had a skin infection or have known a friend or family member who's ever had a skin infection? Why don't you raise your hand if you have? That's a lot of people. We've got a whole room here. Okay, second question. How many people in this room have ever had a MRSA skin infection or have known someone, either friend, family, schoolmate, classmate, who's ever had a MRSA infection? Raise your hand. That's astounding. That's a lot of people. So hopefully tonight's talk will be of personal interest and I think of scientific interest for you. And I'd like to start the talk tonight with a quote. This is one from an article that I recently read. And this quote is from Robert Mullering, who's a very prominent infectious disease physician, who states, "As we read anxiously about the possibility of a worldwide pandemic of avian influenza, another epidemic is actually happening in the United States and elsewhere. Methicillin-resistant strains of Staphylococcus aureus have emerged as community-acquired pathogens capable of causing serious disease." And that will be my focus tonight. I'm in particular going to outline the major topics related to these MRSA or methicillin-resistant Staph aureus infections. I'll begin with a little background, helping you to understand the basics about this organism so we're all talking on the same terms. Next, I'll go through the mechanisms of the multi-drug resistance so you understand this is resistance not just to one antibiotic, to multiple antibiotics. Third, I'll go over some basic epidemiology that backs up our perception that this is a huge problem and that we're all feeling it and seeing it. There is actual good scientific data to back this up. I'll then discuss some of the practical clinical manifestations that we see on a regular basis in the clinical and emergency room setting and in the hospital setting. And then I'd like to focus on some of the life-threatening community-acquired infections. This is perhaps the area that's of most interest to people in the room, that superbug that is out there in the community. Then I'll go over some issues related to prevention and policy, and I'll conclude with a few future strategies. And we are in desperate need of some future strategies for methicillin-resistant Staph aureus infection. Now, to begin with, let's look at the organism. The organism that we're talking about is Staphylococcus organism. This is an extremely common organism that is on many people's skin. In the microbiology lab, when we look at this organism, what you can see here is a culture plate that is the typical way that we grow this bug. It has a golden-like appearance on the culture plate. We can actually take these bugs and do a gram stain of them where we can see what they look like under the microscope. And under the microscope, this gram stain shows these, what we call gram-positive cocci. Now, what are the roots of the origins for this word? The word Staphylococcus is a Greek word, and it means grape-like clusters. The word aureus is a Latin word that has the derivative of golden as the meaning of it, and this was the basic monetary unit of ancient Rome. So the name Staphylococcus aureus fits when you think about the derivatives, this grape-like clusters of organisms that appear golden in appearance when we grow them in the laboratory. This is what the bug looks like up close and in person when you're looking at it under a microscope, blown up to large proportions. And this is a schematic showing you what this organism looks like. It has a cell wall and it has a membrane, and I'll show you more details about it in a minute. But what is methicillin-resistant Staph aureus? Methicillin-resistant Staph aureus is the terminology we use to describe resistance to methicillin and a whole group of antibiotics that are very similar to methicillin. The reason this is such a problem is because these antibiotics are common antibiotics that are readily available to treat this infection. So the problem with methicillin-resistant Staph aureus is, first of all, that it's a resistant organism. But I think perhaps the more interesting thing is, what are the factors that turn this bug from a garden variety staph into this bug, our superbug? Now, the question is, what are the factors? And if you look at these, there's probably 3 factors that play the biggest role. First of all, the reason this has garnered so much public attention is this bug has emerged out in the community. We've known about this bug in the hospital for years and years and years, but this has emerged in the community, and it hits much closer to home when people hear about someone that they know who was stricken down and died, who was otherwise a previously healthy person. Secondly, this organism is not only resistant to methicillin, we're seeing an organism that has resistance to many antibiotics, as I'll show you. The third is that this is a highly virulent pathogen. I think there indeed is something special and different about the bug that is out in the community that in some ways makes it worse than the bug that we've seen for years in the hospital setting. So let's look at how our antibiotics work. And if you understand how the antibiotics work, you can understand how this organism, Staph aureus, has outsmarted us basically each decade that we come up with a new strategy. First of all, understanding the basic structure of this organism is very important. This is an organism that has a cell wall that's the outer area that looks like these brick-like structures. There are these yellow penicillin binding proteins here that are essentially critical proteins that cross-link the cell wall. All of these bacteria have a cell membrane that are these gram-positive staph bacteria, and they have a DNA. And that's very important when you look at genetic reasons why we see resistance. Well, a key component that I'm going to come back to several times are these penicillin binding proteins. These penicillin binding proteins, as you can see, are like the workers that cross-link the cell wall. Imagine that this bacteria is like building a wall around itself, and it's using these penicillin binding proteins to link together the walls, much like you would be cementing together bricks around your house to protect your house. That's the function of those penicillin binding proteins. Well, what's our history that we have seen? This is a very storied history that this organism has ever since the advent of antibiotics in modern times. In 1942, this organism developed resistance to penicillin. This was a tremendous blow at the time. 1961, we saw methicillin-resistant Staph aureus first emerge. So obviously, MRSA is not a new problem. This has been around for a long time. There are new aspects of it that I will go over later. In 1996, we saw a very disappointing finding where the first emergence of so-called vancomycin intermediate-resistant staph was reported. This is the name of Visa is what's given to this. In 1999 and 2001, we also saw some resistance develop to some of the newer antibiotics that had been developed to treat these MRSA infections, daptomycin resistance and linezolid resistance. I'm going to focus on those things above the red line predominantly in the talk this evening. Now, what about penicillin? Believe it or not, back around in World War II time, penicillin was a very good antibiotic to treat staph infections. Who would ever have imagined that? But penicillin used to be very good. How did it work? What penicillin did is that it systematically binds to all of these, what's depicted here is these yellow penicillin binding proteins. In essence, what it does is that it ties up these workers that are responsible for building the cell wall of the bacteria, and essentially the cell wall falls apart. It can't regenerate, and as you can see in this slide, the cell wall starts to develop holes in it, and it kills the bacteria. Well, what went wrong? In 1942, we know that this organism acquired a new gene. It acquired it in what we call a plasmid, which is like an extra little snippet of bacteria shown here in this red little circle. This extra bacteria was acquired, this extra little DNA was acquired from another bacteria, and it contained a gene called the BLA-Z gene. This gene, unfortunately, made an enzyme, as depicted by this orange arrow here, that was an enzyme known as beta-lactamase. What did that beta-lactamase do? Unfortunately, what it did is that it flat out destroys penicillin. Penicillin is shaped kind of like a ring, and it opened up the ring and made the antibiotic not useful. So this was essentially the modern advent where we started to lose penicillin as an effective antibiotic against staph infections. Well, there was discoveries to come up with a second sort of generation to treat these staph infections. And what came about was new antibiotics like nafcillin, methicillin, oxacillin, cephalexin, Keflex, ceftriaxone. We have a whole flurry of antibiotics that were developed that were very good staphylococcal antibiotics. As shown here, the one we use in the hospital, probably the most, is known as nafcillin. We use that a lot more than methicillin, but you could use those terms interchangeably. Now, when we see this nafcillin, how does it work? It works just like penicillin. It binds to the penicillin binding protein, but that arrow or that enzyme that comes out and destroys penicillin is not capable of destroying nafcillin. You can imagine that nafcillin was shaped in a way that it has a shield so that this enzyme doesn't destroy it. It's protected against that beta-lactamase. Anybody that's ever taken the antibiotic Augmentin is a combination of amoxicillin and clavulanic acid. That clavulanic acid is added on to amoxicillin to prevent that arrow, that enzyme, from destroying the amoxicillin. Nafcillin does it in a different way. It actually has a shield around in its structure. Staphylococcus outsmarted us there. In 1961, we saw the first emergence of so-called methicillin-resistant Staph aureus. Now, how did this happen? This happened with the acquisition of a new genetic mutation that was known as the MEK-A gene mutation. What this MEK-A gene does is that it makes a new protein that's the worker that builds the cell walls together. The new protein is called penicillin binding protein 2A, or 2A, A for altered. This new protein, what it can do is it can come into the cell after it's made and essentially replace the usual protein that we're used to seeing there, the penicillin binding protein. This new protein, however, is not a good receptor for the nafcillin to bind. So this antibiotic comes up trying to bind to these proteins, and it just can't bind to it. Unlike, for example, the old one that's not MRSA, where the antibiotic would bind and essentially destroy the cell wall. So with this, the unfortunate news is when you have this nafcillin resistance, you're resistant to a multitude of antibiotics that are very similar to nafcillin. We have groups of antibiotics we call beta-lactams, which are very common and numerous, and essentially we lost that entire class of antibiotics to these MRSA infections once this developed. So a very important milestone in the development of this problem with MRSA. So what do we have to offer after that? Well, historically, what we use predominantly to treat these infections, especially the serious ones, because this was usually occurring in the hospital back in the 60s and 70s and 80s, we used an antibiotic called vancomycin. And vancomycin does not work like nafcillin. As you can see here, what vancomycin does is that it basically wraps itself around these building blocks or these bricks. So the way to think of this is that the nafcillin is actually tying up the workers that are building the wall of the house. What vancomycin is doing, it's wrapping itself around the bricks so they can't be laid down. Two completely different mechanisms of action. Now, how does Staphylococcus outsmart us here? Now, this one is the biggest mystery. This is an amazing phenomenon. If you use vancomycin and you use it appropriately and it's effective and there's no resistance there, it has the same net result as nafcillin does if MRSA is not there. It destroys the cell wall, it doesn't regenerate, the organism falls apart, and you kill it. But what has gone wrong to some degree with vancomycin? What this organism can do, which is amazing, is that it's capable of making this cloud or this extra thick wall around itself so that vancomycin thinks it's doing its job, but if you look at it, it's all tied up in the outside of the cell wall over there. It's not even getting in to the core of essentially the wall around the house of this bacteria, and it's not able to break down the wall of the bacteria. So this organism has slowly evolved in a way that we see more and more of these staphylococcal isolates. We call this resistance vancomycin intermediate resistant staph, or VISA, and this first emerged globally in 1996. Now, how this occurred and how this organism ingeniously figured this out, we do not know. This is an interesting quote where it says, "The molecular mechanism for these alterations in peptidoglycan biosynthesis are unexplained." And this is a quote from Franklin Lowry. So to this day, it's not exactly clear how the genetic evolution has occurred that has led to this extra thick cell wall that can occur in these staphylococcal isolates. So let me shift gears to some basic epidemiology. That's the background for how these antibiotics work and how the organism has outsmarted it. Now, how big a problem is this? Where is the problem? What do we know about it? Well, first of all, the first question to ask is, who can get MRSA? Anyone. Absolutely. Thank you. Anyone can get MRSA. It can happen in the hospital, it can happen in the community, it can happen to the young, it can happen to the old, it can happen to the fit, it can happen to the people who are not fit. It can happen to anyone, and that's the key point. There are probably some groups of individuals who have a slightly higher risk, but we now know from epidemiology and from clinical experience, anyone can get MRSA, and that's what makes it a very scary phenomenon. Now, the two major places to think about where people get it, so that's who can get it, now where people get it, the two places to divide in your mind are things that happen with these infections in the hospital, and we call those hospital-acquired, or community-acquired. What's new in the last really decade is this whole phenomenon of this problem exploding out in the community. That's what's truly different. Now, how do people get this infection? They generally get it from person-to-person transmission. Many people carry this bug on their skin, and they pass it to other people. Okay? So where do people have it on their body? Those people that carry around staph, where do they have it? They have it predominantly in their nose, in the nares, in the axilla, which is the armpit area, and down in the groin area. Those are the three places in the body where there's the highest concentration. You can, however, have it anywhere on the skin, anywhere on the body, but those are the areas of the body where we see the greatest concentration. How many people actually carry around staph, and particularly Staph aureus, which is the bug we're talking about? Now, I'm not first of all talking about the resistant staph, but just your everyday Staph aureus that's not MRSA. Well, about 60% of the population at some point in their life carry this bug around. That's kind of a hard thing to imagine. But basically, almost 2 out of 3 people carry this at some point. About 1 out of 5 people, or 20%, are what we call persistent carriers, meaning you could go there and culture them every year, and they're pretty likely to be carrying this bug each time. Then there's about 20%, or 1 out of 5 again, that are non-carriers that we believe just for some reason that bug doesn't latch on to their skin cells or nose cells very well, and they're somewhat immune to carrying this bug around. Now, what about MRSA? We know that the rate of people carrying MRSA is significantly less. It's probably on the order of 1 to 2%, certainly less than 5%. Now, those numbers are probably changing and probably increasing, but the large epidemiology studies suggest MRSA carriage out in the community especially is less than 5% of people. Although, like I said, those numbers are probably rapidly changing. The next question is then, what are some of the risk factors in particular for people acquiring this or transmitting this to other people? The CDC likes to think of this as the 5 C's. Number 1, crowded conditions. Number 2, contact, the skin-to-skin contact. Number 3, compromised skin, for example, when people have cuts and abrasions. Number 4, contaminated items and surfaces, such as towels that might be contaminated. And the last C is lack of cleanliness. All of these are probably risk factors that can be involved with the transmission of this organism from one person to another. What type of evidence do we have that this is a big problem in the hospital? This graphic is looking at the proportion of MRSA among patients in the intensive care unit. So for those of you who don't have a lot of experience with this type of terminology, intensive care unit, ICU, these are the sickest patients in the hospital. They're very ill patients. And these individuals, what we're looking at in this graph is the proportion from 1995 to 2004. And what you can see is that more than 50% of the staph that is isolated in those patients is actually MRSA. So in other words, the person, if you grow out staph from their body, they've got a greater than 50% chance, if they're in an ICU now, of having this bug be a MRSA bug. And this is really showing the magnitude of how severe this problem is in the hospital setting. Now, what about out in the community? There was the emergence of a very famous strain that we call the USA 300 clone. This emerged in the community probably around the year 2000. It really wasn't seen to any significant degree before the year 2000. Fortunately, it's sensitive to a lot of antibiotics. It's also resistant to certainly a group of antibiotics, but it's not the highest level of resistance. For example, they're usually not resistant to vancomycin. This is an organism that we know has a unique genetic makeup. It has what we call the type 4 MRSA gene cassette element. In other words, we can see a pattern, a footprint, that from bug to bug that is there in this particular strain where they look basically identical. And one of the things that has been seen over and over again with this bug out in the community is that it carries a gene that codes for a toxin known as the Panton-Valentine leukocidin. This is very common. I'll go over that in a little more detail. We don't actually know how critical this toxin is. We believe it plays a role, but it may be one of a number of players that are toxins that turn this bug into a superbug. Now, what is the epidemiology data that we've seen on a practical basis for medical studies? This is a study done in Baltimore in their Veterans Association settings, in emergency rooms and in their emergency care services system. And this graphic here is really showing you the proportion of MRSA infections for every 1,000 people who came in for any medical visit to these emergency room services. Most of these visits were skin and soft tissue infections, and about 2/3 of these people had had no major health care in the contact in the prior year. So we really believe they were getting these bugs probably out in the community. And what this graphic clearly shows is a dramatic uptick that occurred around 2001, 2002, 2003. This absolutely mirrors what I saw in my own clinical practice here at Harborview at the University of Washington, where around that time we saw this tremendous upsurge in the number of people coming in with skin and soft tissue infections that were caused by MRSA. What other kind of evidence do we have that suggests this is a major problem out in the community? This is an interesting study that was published in the New England Journal about a year ago, and it looked at people who came into an emergency room with skin and soft tissue infections. And the question they asked in these 11 emergency rooms during the year 2004 was they asked the question, if someone comes in with a skin infection and we culture it, what's the chance that we're going to grow out MRSA? And you can look at this bar going down here. Essentially, more than 50% of most of these emergency rooms, that's what they grew out. That is not what we would have seen 10, 15 years ago. We would not have seen more than 50% of people showing up to an emergency room with a skin infection having MRSA. Now, what they also found was a very high incidence of these strains that they grew out having this toxin that I mentioned called the Panton-Valentine leukocidin. Whether or not that's a marker for the superbug or one of the causes for it being a superbug is still debatable, but they saw that marker very frequently. Now, this is an interesting article that came out in the New England Journal in 2005, and I think it brought the attention to the public that MRSA can occur among the biggest and most fit athletes. And this was an outbreak that occurred in the St. Louis Rams players in 2003. And I love this X's and O's that appeared in a figure in the New England Journal. And these colored in X's and O's are the players that acquired the MRSA. And it actually makes a lot of sense because the guys on the line are most often sort of, grabbing each other and rubbing each other in their face and, grabbing onto their arms. So it makes sense that these individuals would be at the highest risk for acquiring these MRSA. There were a number of cases in professional athletes that have been reported. Essentially in almost every major sport now, we've seen MRSA outbreaks occur at both the college level and at the professional level. And again, it's been seen in the high school level and on down. Now, the article that really got this on the map, and they got your senators and congressmen and people really to wake up how serious this problem was an article that came out this fall that looked at the invasive MRSA that occurred during the United States in 1 year, in 2005. And this data is astounding. What they found was they found more than 94,000 cases of invasive MRSA. And when we say invasive, we're talking about people who are extremely ill, who need to come into the hospital and have intense medical care to take care of a serious problem. 75% of these invasive cases were bacteremia, which means a bloodstream infection. And if anybody's ever known anybody that's had a staph bloodstream infection, that is a serious problem, a very serious problem. The most profound statistic in this article was that there was an estimated 18,650 deaths attributable to MRSA during that 1 year. This particular clone that I talked about a minute ago, this USA 300, accounted for most of the cases that had occurred in the community. Overall, most of these cases actually began in the hospital. So not to overly scare you, most of these were medical care associated, people in the hospital who got sick and who died. But of the ones in the community, most were this particular isolate that I was telling you about. And there were some racial differences. There was a 2 times greater incidence among African Americans than among Caucasians. Now, the statistic, once again, to drill down on, is this estimated 18,650 deaths. This is more deaths, almost twice the number of deaths that occurred among people who died from HIV and AIDS in that same year. And I'm very involved in HIV and AIDS in clinical care and can tell you that's a huge problem in the United States. To see this kind of number is a really astounding number and tells you how serious this problem is and how much attention needs to be directed towards it. Now let me shift gears and talk about some of the clinical manifestations. Once again, this problem can occur both in the community and in the hospital setting. And in the community, the major thing we see are these skin and soft tissue infections. We can also rarely see people develop pneumonia, which is very unusual but can be life-threatening. In the hospital, what we predominantly see are people who develop what we call nosocomial pneumonia, a pneumonia while they're in the hospital. And we can see infections that are among people who have IV catheters in for IVs and medicines are getting through intravenous route. In the middle here, I've got patients who have bacteremia and endocarditis. That's a bloodstream infection and a heart valve infection. Those can occur from either people getting it from the community or in the hospital, but what's in the middle there are probably the most serious infections that we see, probably along with these nosocomial pneumonias. Now, out in the community, what are we seeing predominantly? We're seeing these skin and soft tissue infections. What do they look like? These are some typical examples of these skin and soft tissue infections. People come in with painful, swollen areas that are like giant boils, basically. Now, this is an example of a patient who had a very tender, swollen area in his arm. This is another patient who had been treated with an oral antibiotic called cephalexin or Keflex, common antibiotic, did not get better, had a serious area up around the upper thigh area, erythema around it, redness, and that required actually some surgery to open that up and take care of it. This individual came in, and guess what he thought he had? Spider bite, exactly. He came in, thought he had a spider bite, and it actually kind of looks like 2 puncture wounds there. And indeed, when we cultured this was 4+ or full growth of MRSA. And he responded very well to after we opened this up and got him on good antibiotics. Now, how do we treat these? First of all, these infections often form abscesses. So one of the keys to draining any abscess or to treating any abscess is to actually open it up. This is really the cornerstone for managing most of these MRSA infections, is to get them opened up so that you can actually clear out most of the infection. And many times we need to follow these up with some antibiotics. Sometimes patients just need it opened up and no antibiotics, but often we do need to follow these with some antibiotics. Some very common antibiotics that you're probably all very familiar with, like Bactrim and Septra, work very well to treat these MRSA infections. Doxycycline, minocycline, they work pretty well. Clindamycin, pretty well, but not quite as good. And then we have newer antibiotics if the patients are very seriously ill with these skin infections and need to come in the hospital. Antibiotics like vancomycin, linezolid, daptomycin, these are all generally effective for these skin infections. So we have antibiotics that will work against these, but the number of people that are coming in with these is really a substantial number and a tremendous increase from what we've seen before. So what about spider bites? This is what a spider bite looks like if you get one in the Northwest. And not many people actually get this bad of a reaction, but this is a spider bite from a patient that I saw who developed this severe swelling and redness around her knee area after bitten by one of these spiders. Anybody know what the main spider is in the Northwest? Hobo spider. A couple people said it. Now, the CDC is very interested in this. They're trying to educate the public that if you think you have a spider bite, go in and see your medical provider because you may actually have a serious staph infection on your skin. So they have these pamphlets and flyers that are actually out there trying to educate the public about this misdiagnosis that both medical providers and people themselves have thinking it's a spider bite. Well, what is a hobo spider bite? A hobo spider, the technical name for this is Tignaria agrestis. This is a male and female hobo spider, and they have this very characteristic herringbone pattern around their essential backside, right along in here, this herringbone pattern. And that's what distinguishes them. They're very common in the Northwest. Many of you have probably seen them in your house and around. And it's unlikely that people get serious spider bites from these, but it is important to know that this is the main spider in the Northwest. Now, what do we do when people get these infections over and over again? A lot of times we're not able to stop them getting these infections if they continue to be re-exposed over and over again to these organisms from other people or sexual partners. However, there are antibiotics that can do a pretty good job of getting rid of the bugs in the nose, and that's called mupirocin or Bactroban. We typically give this for about 5 days and then repeat it a month later. There's a topical wash, chlorhexidine or hexachlorophene, that both work well for getting rid of this if people scrub it pretty well in their armpit and down in the groin area. These aren't perfect by any stretch of the imagination. The relapse rate's pretty high, and if people get exposed again, you're back to square one. They've got the bug on their skin again. So not a perfect solution, but in some instances we will try these to prevent these recurrent infections. Now let me shift gears to some of the life-threatening infections. The first glimpse of how severe this problem in the community could be came in 1999. There was a report in the MMWR 4 pediatric deaths among children who were acquiring these methicillin-resistant strains out in the community, and this was reported in Minnesota and North Dakota during a 3-year period. Now, further studies, many of them have documented these very serious infections, and certainly there have been a number of these that have now been reported as severe skin infections, so-called necrotizing fasciitis. And this was reported in the New England Journal in 2005 with a big outbreak in Los Angeles. One of the things that we've seen that has really alarmed us are some of these cases of individuals who develop pneumonia that is MRSA. We don't normally think of people getting a staph infection for pneumonia unless, for example, they have had influenza. But there have now been a number of these reports where people have come into the hospital totally healthy and have had a life-threatening infection with this MRSA pneumonia. I don't want everyone in the room leaving tonight thinking that this is a common problem. It's a rare problem. It is one that we're trying to educate medical providers about in the event that a previously healthy person comes in and has a very unusual life-threatening pneumonia. We want them to know about this because the treatment would be different than what we normally use to treat people who come in with pneumonia. This example was a 49-year-old man who was totally healthy, who was airlifted from Alaska in severe respiratory distress. This is not a normal chest x-ray. Normally you should not see all this white area all in the lungs. All in here are these big patches of white that really don't tell us a whole lot except there's something serious going on. However, when we did a CAT scan at Harborview, and if you look at this as basically like a slice of bread of one area of the lungs, what you see is very remarkable. What you can see are basically holes throughout the entire lung. Basically, staph and MRSA here was turning the lungs into almost a Swiss cheese-like texture and appearance. Numerous holes throughout the lung. So this was an example in one of the first cases that I saw of these severe community-acquired pneumonias that were caused by MRSA. Fortunately, this individual was put on an appropriate antibiotic when he arrived at Harborview, and he did survive and left the hospital after a very long course. And it's very fortunate that he survived, and we're obviously extremely pleased with that outcome. There are patients who have died in this setting. Now, there was a recent advisory that just came out a couple weeks ago from the CDC. And this was an alert regarding influenza-associated pediatric mortality and Staph aureus co-infection. And what does this mean? What this means is they are trying to alert medical providers that children who get influenza can also get a staph infection, especially with MRSA, and have a life-threatening clinical course and even death in this scenario. This has occurred on a much more frequent rate than has been seen in historical years. And what we've seen is in the last several years, this big upsurge in the number of cases that have occurred. We're still talking about less than 100 of these cases in the last several years. But nevertheless, there's an alarm out there because as influenza season starts to march through many places of the country, the concern is that these MRSA infections may occur more frequently, especially in kids and people who have pneumonia. And the idea here is that the lungs are injured and damaged by influenza. You throw this staph organism on top of that, making this toxins and causing damage to the lung. It's just too much for people to often be able to handle. Now, what are the secrets of this superbug? Honestly, we really don't know everything about this superbug. But what we know is a number of studies are starting to, I think, assemble an array of tools that this organism has to make it a very, very powerful organism. The three most important tools that we know about now are three toxins. The first one is known as so-called PSM, or phenol-soluble modulants. The second toxin is known as an alpha hemolysin, shown in the middle here. And the third is the toxin that I've been telling you about several times, called the panton-valentine leukocidin, which is actually two proteins that are joined together, and then they join in a whole group or ring of 7 proteins. Now, an example of one of these toxins and what it can do is what we have seen with this particular toxin known as the panton-valentine leukocidin. This is a toxin that we know can destroy tissues in animals when it's been studied, in mice and rabbits and other animals. And we know that it has the capability to destroy white blood cells and skin cells. And what this particular graphic is showing you is how it does this. It binds to a particular area of the membrane of white blood cells, and this is called the lytic pore. And lytic means it's actually putting a hole in the pore, making a little area in there, and the result is as follows. That's what happens to the cell. Basically, it is flat out destroyed and dissolved by this particular toxin. Now, as I've said, we do not know if this is the key toxin, one of the major players, or really we're being fooled by it and it's really not one of the important toxins, and there are others that are really the critical toxins. But all the available evidence suggests right now that there's probably a cluster of what we call virulence factors that this MRSA bug is carrying around with it. Now, what makes this different is it appears that the MRSA versus the garden variety staph that we've seen out in the community for years and years and years, that MRSA bug appears to be more likely carrying around these bad toxins that cause really bad things to happen. And that's one of the key concepts to understand why we think this bug is causing so many problems. Now let me shift gears to some prevention and policy issues. I would really like to divert all of your attention to a wonderful resource through the Centers for Disease Control. The Centers for Disease Control, from an educational standpoint, I think has really stepped up to the plate with some excellent resources. I think most people in this room are probably very web savvy. If you get on any search engine and search CDC and MRSA, you're going to pretty quickly find their major website on MRSA, which has two major sections: nosocomial, which is the hospital, and community acquired, or CA is the abbreviation they use for community acquired. If you just start clicking around on the community acquired site, you will find essentially all of the particular slides that I'm going to show you, and there is a wealth of questions that are answered on that website. If you are in a public health position, you have also been involved in this. For example, our King County Public Health has played a very active role with MRSA, and we have a phenomenal public health division here in King County, and Jeff Duchin has done a wonderful job educating much of the community and being very involved in these particular issues. But looking at the site, and I've actually got the URL there, but it's very easy to find, there is this great resource for the public where they have a number of questions answered. Now, here's an example of something that they would have on their website. How can I prevent staph or MRSA skin infections? And they answer this by the following on the CDC site. Number one, keep your hands clean by washing thoroughly with soap and water or using an alcohol-based hand sanitizer. Alcohol-based is the key. Number two, keep cuts and scrapes clean and covered with the bandage until healed. Some people say don't cover wounds. Now with this and with MRSA, I think times have changed and we recommend covering these wounds. Number three, avoid contact with other people's wounds or bandages. You know, most people don't want to touch somebody else's wound, but from a common sense standpoint, you may be helping somebody else change a Band-Aid or get it off. You have to be very careful now about doing that. And number four, avoid sharing personal items such as towels and razors. That's particularly important, say, for example, in athletic settings where they used to have, you know, sort of one person grabs a towel, passes it on to someone else. I know a number of athletic teams have instigated strict policies with that. Now, the CDC has also put out some wonderful educational pamphlets and brochures that can be used, for example, if you're involved in a school or other places in a gym where you want to give people some general advice that CDC endorsed. And this is basically some flyers that they have. This one says, don't give bacteria a free ride. Washing your hands with soap and water is one of the best ways to prevent diseases. And that's a very true statement. And then number 2 says, sharing isn't always caring. Sharing personal items like towels, razors, or tweezers can spread disease. So these are just some practical tips for people in the community. The one that's probably the most hot button topic is the schools. The Centers for Disease Control has a number of questions they've addressed on their site regarding MRSA in the schools. For example, what type of infection does MRSA cause? They address the issues of should schools be closed because of a MRSA infection? Should the school be closed to be cleaned and disinfected when an MRSA infection occurs, and so on. So they have a number of specific questions that they address, and I think these are good general pieces of advice. Anyone who's at a school or a facility where they have to make decisions like this, you should get your health officials involved either at the local, regional, or state level, depending on how serious the problem is, but generally starting off, for example, with your local King County area if you live in King County. Now, another hot button topic is athletes. Now, the CDC has a number of practical questions they address regarding athletes and what to do when an athlete has MRSA and how is this handled. And for example, here's a question on their site. Should athletes with MRSA skin infections be excluded from participation? Their answer to this on the CDC site is if sport-specific rules do not exist in general, athletes should be excluded if wounds cannot be properly covered during participation. And that certainly can be done in many sports. You can cover it up and it's not a problem. However, if you have a wrestler that's got a big gaping staph wound on their arm and you're putting a big Band-Aid on it, and that thing could easily just be knocked off right away in the first 30 seconds of a wrestling match, that's not going to be an appropriate coverage of that MRSA wound infection. On the other hand, you have some kid that's playing in a soccer game that's got a MRSA infection on their hip area. They've got it covered up. They've got shorts on and a shirt on. That would be considered a wound that you could easily cover up, and that person in general would be allowed to participate in the athletic event. Now, what about future strategies? Let me close here. As I mentioned at the outset, we are in desperate need of new strategies. We are not winning this war against MRSA. There is no question about it. It's not because people aren't trying. It's not because there aren't a number of dedicated health professionals throughout the United States. This is a problem that has exploded in our face, and we do not have right now the adequate tools and resources to really shut this thing down. But what are some potential strategies? One of those would be to improve our surveillance. And this doesn't just mean blind surveillance, but it means really very carefully thought out surveillance methods that give us at a national, regional level, and molecular level a better handle on why this problem has occurred. And we really, to this day, aren't 100% clear why this whole problem has emerged. And to perhaps give us clues to that, and to perhaps give us a clue into where are we going. Are we ramping up further? Are we slowing down? All of those issues would be important to garner from enhanced surveillance. The second would be, we have a lot of effective antibiotics. And over again in the hospital, we've seen people not doing well with traditional antibiotics. So we need to be looking at some federal funding for some aggressive studies to look at novel combinations of existing antibiotics that we now have. Certainly, there's tremendous interest in the third item, which is novel antimicrobials, thinking outside of the box of traditional types of antibiotics, but antibiotics that work in a completely different way, whereby we could really not imagine that resistance would occur very soon, or that really would have some very unique strategy whereby we wouldn't see staph step up to the plate and develop resistance within a couple of years. We would like to also see novel decontamination products. We have some products that can get rid of staph on the skin, but they're not uniformly effective. People relapse. They don't have long-lasting effects in many, many people. So it would be wonderful to see some novel strategies for decontaminating people who have this. The last and the holy grail, in my mind, is a staphylococcal vaccine, a Staph aureus vaccine that really doesn't even care whether or not it's a resistant bug or not a resistant bug. It shuts down Staph aureus, period. That essentially is where we're at in terms of really needing the overall approach that is likely to work. Now, I appreciate your time and effort. What I've tried to do is lead you through somewhat of an odyssey of where we are now in 2008 with this tremendous problem. I've hopefully given you some insights into the understanding behind how our antibiotics work, how this organism has outsmarted us, what some of the problems are out in the community, how the degree of this has really increased in recent years. Hopefully you have some new insights into how this bug is different than what we were seeing 15, 20 years ago in the hospital setting. And last but not least, I hope I've directed you to where that you can find some good resources at the CDC for some particular information that may be very relevant to your own personal hygiene and safety. And thank you very much for your attention. Thank you.
So we talk about these staph infections as often coming from the hospital. You know, there's this joke about, well, I don't know if it's a joke, about old folks, you know, the worst thing is to fall and break something because you might go to the hospital, which is fatal. Why is it that we have these things in hospitals? I mean, if anybody understands that germs cause disease, it's doctors.
The question really is, you know, for these staph organisms, and really other organisms as well too, why is the hospital such a bad place in terms of these organisms? The major reason that I think we can explain this is that there's such a tight clustering of very sick patients in an environment where they are not only in a hospital where their immune system is compromised, their barriers to infection, their skin barriers, their lung barriers are all broken down in a normal fashion. So we tend to see people having all the sort of perfect storm in a hospital setting where these organisms essentially live and breathe throughout the hospital. The second major factor in the hospital is it's a place because people are so sick, we're frequently giving them antibiotics. So it's a breeding ground for this battle between these bacteria and our antibiotics, and so it's a breeding ground for antibiotic resistance. So for those factors, that's one of the reasons the hospital is such a horrible place. Now, the dogma for staph for years was every bad staph infection came from the hospital. But what I've really tried to emphasize tonight is we really have now two worlds of the staph. We truly have things that are happening in the hospital, but we truly have things that are out there in the community that are just being passed around from person to person in the community where they're clearly not getting it from the hospital. So there's now these two separate worlds in the staph world. I don't know if you want to add anything.
Well, facetiously, it's Sutton's Law. It's where the money is. Why did Willie Sutton rob the banks? He said, why do you rob banks? He says, that's where the money is. I mean, there is a concentration of pathology there, and so we do have, and again, particularly our hospital, and that's why we're a little leery of, you know, where they track incidence of these infections by hospital, because the patients that we see in our catchment area are really a distillation of the severe pathology all over. We would be dinged horribly by any accrediting body that looked at our incidence. So it's both, and we have actually learned that we have to do a much better job at washing our hands before and after every patient, and we actually ask our patients to remind us to do that. We have dispensers with alcohol-based hand lotions.
Thousands of them now.
Thousands of them. Outside of
You can't take two steps without them. It's more than you have Starbucks around here, you know.
Yeah.
I mean, they're everywhere.
Every single patient room, every single exam room. And as you see, if you look at the lay press, England, they've outlawed ties, and now everybody has to wear basically surgical scrubs and not street clothes.
Because the ties, people lean over and it gets contaminated when they're examining the patient.
Yeah, you don't even want to touch my tie in $1 million.
I don't wear a tie anymore.
Yeah. Yes.
Do pathogens develop resistance to vaccines just as antibiotics?
Yeah, that's an interesting question. So the question is, do some of these organisms actually have what we call immune escape from vaccines? Most of these bacterial pathogens are very smart, but not that smart. Certain pathogens, for example, like HIV, has an incredible ability to evade the immunizations that have occurred from an immune standpoint. You know, in terms of changing its outer surface proteins, and that's why we really can't get a vaccine so far for HIV. But most of these bacteria and some of these encapsulated organisms that Hugh talked about, like with pneumococcus and H. flu and meningococcus, these organisms, we clearly have developed very effective vaccines that the organisms have not worked a way around the vaccine. With Staphylococcus, we do not have a vaccine that is currently available. There are ones that are being researched now. There was one that moved along fairly far, and then very disappointing results occurred, not because we think the organism outsmarted it, because the vaccine wasn't good enough to develop the right kind of immune response. So I think once we see the right vaccine, I think it's very possible we could someday see some kind of innovative vaccine approach, even something that could be as simple as even patients admitted to the hospital where there could be some kind of rapid upregulation of their immune system that may help them to fight off any staph infection while they're in the hospital. But clearly the most effective strategy would be as if this became part of a routine vaccination that was available. And, you know, and everybody thinks, oh, that's kind of preposterous thinking about another vaccine. But when you start talking about 18,000 deaths a year and young kids dying, someday we may really be looking at thinking about a more pervasive vaccine strategy for staph if the problem continues to accelerate at the rate it's at.
But there is kind of evolutionary drift too. You know, after we take the spleen out, somebody gets their spleen taken out for trauma. Before we discharge them, we routinely inoculate them and give them a vaccine against H flu and a variety of them. But it's only 14 of the, you know, almost 20 different varieties. And we know we're missing them, but it's the best we have at times. So that very nature of the way that bacteria reproduce and the fact that, I mean, our genetic engineering industry is based on that fundamental principle is that you can use a virus to stick a piece of DNA in a bacterium or a yeast to make some kind of drug. So it's a double-edged sword. That plasmid insertion is both a blessing and curse.
Okay, Joanne, thank you very much. All right, thank you.
Thanks,
Thank you for
Thanks a
coming
lot
out.
for coming.